is dimethyl biguanide. It's a biguanide diabetic agent. It's actually the only medication of its class. There used to be several more, but they were all pulled off of the market because they caused a deadly side effect, severe lactic acidosis, which I'll circle back to. But it has several different mechanisms in the body. Most importantly, for this talk, it inhibits complex 1 of the electron transport chain that's used in aerobic metabolism. In terms of the kinetics of metformin, the only really important thing from this slide is that it exits the body entirely through the kidneys. So there's no hepatic metabolism whatsoever. And if you have a reduced GFR or NAKI, it can lead to very severe consequences. So getting into the clinically relevant portion of the talk, the toxicity that can be caused by metformin is metformin-associated lactic acidosis. And so what happens if you develop very high levels of metformin in the blood, that inhibition of the electron transport chain of aerobic metabolism can actually shunt you toward anaerobic metabolism, and you can get a severe overproduction and accumulation of lactate and get a very severe life-threatening metabolic acidosis. So there's many millions of people that take metformin. This is an incredibly rare disease to develop, but it is very deadly when it happens. Case series have a mortality rate of almost 50%. So how do we recognize when this may be occurring? You know, out of all of the many millions of people that take metformin, how do we recognize these few cases that may have this deadly metformin-associated lactic acidosis? So we need a conceptual framework to identify those cases. So we try to assign them into one of 3 different categories. We have at the bottom of the slide, metformin unrelated lactic acidosis, or MULA. These are the patients that take metformin, but it's not doing anything harmful. They just happen to be on it, but you know, they're just septic, or they just have decompensated CHF and they have elevated lactic acid for that reason. On the opposite end of the spectrum, we have MILA. This is a lactic acidosis that's basically entirely due to metformin. This could be someone that downed a whole bottle of metformin before coming in, or they're on a very high dose. And then in the middle ground, you have MALA, or metformin-associated lactic acidosis. This is really probably the diagnosis you would be working with. And you know, in real life, almost everything, there's some middle ground, but in this case, you know, there may be another disease process going on, but there is some contribution to the metformin. And so this is just a graphical depiction of the same thing. I stole from EMCrit. But basically, what you want to be able to do is identify the cases on the left-hand side, the MALA and the MILA, that you know, there's concern that they have this very deadly toxicity from metformin, so you can treat them appropriately. The MULA cases, you would just be treating whatever other disease process is going on, and you know, the metformin is not really a problem. So what do we look for to identify those cases, or what should tip us off that this may be going on in a patient that's on metformin? So there's a few different things. So obviously, if they're on a very high dose of metformin, or they took a massive metformin overdose, that's very concerning. And then the next thing would be the GFR, the kidney function. If they have a markedly reduced GFR, particularly if it's chronic or subacute, and you know, there's reason to believe that the metformin had some time to accumulate, it's very concerning and is going to make you think more MILA or MALA. And then obviously, if there's no other cause that you can identify of why their lactate would be so high, and then you know, if you have done your typical supportive measures, you've given them 2 liters of fluids and the lactate's not clearing at all, that would also be very concerning. Opposite of all of those would hold true for MULA. So if we've recognized that our patient may have metformin-associated lactic acidosis, or there's enough concern for it, how do we manage it? It's actually fairly simple and goes back to pretty basic principles of toxicology. Of course, you want to decontaminate them and give them activated charcoal if you can, if you're not limited by nausea and vomiting and they present in a reasonable time frame. Metformin is typically thought of as a diabetic agent that does not cause hypoglycemia, but if you take 25 grams of it, it can. So you want to manage extremes of hypoglycemia and hyperglycemia if they occur. All of these people are going to need some volume resuscitation. It's kind of an interesting subject. There's no research out there on it, but you can imagine people that have a reduced GFR that are already severely acidotic are not the group that you want to flood with normal saline because it can worsen hyperchloremic acidosis. By the same token, you may not want to flood them with lactated ringers because this is one of the few populations that the extra lactate may actually be a problem. But the benefit probably far outweighs the risk of either of those. And there's no evidence to pick one or the other. The mainstay of treatment for this condition is enhanced elimination or dialysis. So I'll go into that in a little more detail. And then there's some evidence for methylene blue metabolic rescue as well. So dialysis is really the ideal treatment for this. It basically fixes everything that's wrong. This is how you can actually remove the metformin from the body if the kidneys are not functioning well. It'll correct your acidosis. It'll help you clear your lactate. There is evidence that intermittent hemodialysis is better than CRRT if the patient's blood pressure will tolerate it. The reason for that is that CRRT is just going to take much longer to clear the metformin. Some studies have shown it takes like 15 hours on the machine with CRRT to actually get down to a therapeutic metformin level. So if the patient's blood pressure tolerates it, intermittent hemodialysis is better. And then methylene blue, we're probably familiar with methylene blue as a treatment for methemoglobinemia, but it actually has a lot of other interesting effects in the body. It's theoretically could actually bypass complex 1 of the electron transport chain and serve as an alternative electron carrier. And there's some evidence from the last couple of years that this may actually be extremely effective in metformin-associated lactic acidosis. The case reports have like an 80% survival actually when you use this. And the situation it seems to be the most beneficial in is someone that is already being dialyzed and continues to have kind of refractory hypotension and vasoplegic shock. And there's some evidence that you can use metformin almost as like a 4th or a 5th pressor. And it it inhibits the production of nitric oxide. And so if someone is really sick from metformin-associated lactic acidosis, I think most toxicologists at that point may recommend they use methylene blue as well. But that's pretty much it. It's a pretty simple condition to treat. The big thing is recognizing it, out of all of those millions of people that are on metformin, the few cases that may present. So that's all I have. Summary, it's rare and deadly. Consider it. Anyone that's very sick that is on metformin, particularly if you see a newly reduced GFR, an unexplained severely elevated lactate or severe metabolic acidosis, particularly if there's no other explanation for it. And then the main thing you're going to be thinking of is dialysis. So yeah, that's all I have. Happy to take any questions. Yeah, I mean, I think that if your lactate was that low, it probably wouldn't cause that severe of a metabolic acidosis, and it would be unlikely that you would be dealing with this. It may not be impossible to have an extremely mild contribution of metformin there, but definitely you wouldn't be putting a dialysis catheter in someone that has a lactate of 2 or 3. Any other questions from Zoom? Okay, yeah. Fenformin and buformin are like the 100 years ago metformins, but they killed a bunch of people from lactic acidosis, so no one uses them anymore.